Hi, today we're going to be going over potential routes of administration for a novel schizophrenia drug, and we're going to be looking at long-acting injectables, orals, and sublinguals. First, let's take into consideration some clinical aspects of our patients that we might want to consider when selecting the best route of administration. For schizophrenia, a big issue we have to consider is non-adherence and adverse effects. Approximately 50% of schizophrenia patients do not adhere to their medication regimens, and this non-adherence jeopardizes treatment outcomes and incurs significant medical costs due to rehospitalization, because when they lapse on their treatment, they're more likely to have breakthrough psychotic episodes or other symptoms that might distress them or reduce their quality of life. And while modern antipsychotics are less sedating and less likely to cause movement disorders than first-generation products, they also frequently have side effects, sometimes lesser sedation, but more commonly metabolic disorders such as diabetes or poor glycemic control. And as you can see here on this Kaplan-Meier survival chart over on the right, impaired insight, so the impairment in thinking, judgment, logic, predicts the time to medication non-adherence. So what this is basically saying is that severe schizophrenia with significant cognitive issues makes a patient more likely to not adhere to their medication, which is particularly bad because they may be the patients most in need of medication. The first type we're going to discuss today are long-acting antipsychotics, or LAIs. LAIs are injectable antipsychotics, and the API molecule in these is esterified, so a long-chain fatty acid is attached to the API molecule. And what this does is it causes it to slowly absorb into the patient's bloodstream as that ester bond is broken. So the patient receives an injection, and it very, very slowly deposits into the bloodstream. And this can happen over the course of weeks to months. And what this does is it allows the patient to only come in every few weeks or potentially every few months for their injection. And by controlling the length of that fatty acid chain and the overall stability of the formulation, you can adjust with some level of precision how long you want that to stay in the patient's body. But manufacturing these is far more complicated than a normal oral drug because you have to esterify it, you have to get the particle size of the drug down to a very small and specific amount, and you have to control for a lot of factors in general. And over here on the right, you can see the box for Abilify Maytenia, which is long-acting Abilify. So what are the main advantages and disadvantages of using this LAI route for our medication? Well, the primary advantage is that patients will not need to remember to dose every day. They'll be dosed every few weeks or every few months by a doctor, and it will be out of their hands, which should improve medication adherence. And the studies do show that it improves medication adherence. These drugs are more bioavailable than their oral counterparts because they are being injected and should mostly avoid first-pass metabolism. Patients who are more adherent will have fewer relapses, which is better for their overall health and for the progression of their disease. And by making an LAI, our company will create a harder drug for generic companies to copy. Because it is so complex in its manufacturing, other companies will have trouble copying what we've made. And because this is a very specific treatment, we may have a niche that few other drugs are designed for. This long-acting is difficult to make, and it may have its own particular role in the use of hospital systems and other inpatient settings. The main disadvantages are that patients may not want to be injected and may prefer other medications, especially when these injections are very viscous. It can be quite painful, and patients do not like painful injections. I don't blame them. And due to the long time to reach steady state blood levels because it's slowly absorbing into the blood, patients may not have a therapeutic amount of the drug in them immediately and may need to take a loading dose of another drug to control their symptoms. There may be manufacturing challenges because LAIs are very complex, and especially when scaling up, there may be difficulties creating a consistent product. And it needs to be administered by a doctor, which reduces availability for patients who don't have access to physicians or psychiatrists as often as we would like. As many of you are probably aware, oral delivery is the most common means of delivering drugs to human beings. over 90% of drugs that humans use are delivered orally. And oral tablets are very simple to manufacture in the absence of a time release mechanism. If there's some complex time release mechanism, it can become a more difficult to manufacture drug, but simple tablets are usually some of the easiest things you can manufacture. But because these oral drugs are absorbed through the GI tract, they undergo first-pass metabolism through the liver. So for drugs that are extensively metabolized, you can lose a lot of that in that first pass. Most antipsychotic drugs on the market are oral pills, tablets, or dispersions of some kind for the reasons mentioned earlier. And when you dose daily or bi-daily with these oral antipsychotics, you have a pretty good level of control over the levels of drug in the patient's blood. And as you can see here in this figure, this is pharmacokinetic data for quetiapine or Seroquel. And when dosed orally every 8 hours, you can see it has a Tmax of 1.5 hours and a half-life of about 6 to 7 hours, roughly. So you're dosing about 1.25 times the half-life of the drug, so you're never really having less than 30-40% of the original Cmax in your body. So what are the advantages and disadvantages of this oral dosing? Well, a big advantage is that it is the least invasive route of administration for patients. Patients would rather swallow a pill than receive a painful, viscous injection. It's simple to perform, it's swallowing a pill. It does not require medical oversight in almost all cases. If it's an instant release, it's pretty simple to formulate and produce from a manufacturing perspective. It's possible to have some fairly precise control over that PK, as mentioned, when you dose several times a day. It's easier to produce a variety of different dosage forms because you can just change the size of pills, you can change the amount of active ingredient in pills. There's not complex pharmacokinetic issues that come from how fast it's absorbing. It's pretty simple. Therapeutic levels of the drug can be achieved in just minutes to hours. You don't need a loading dose. You swallow the pill, it usually works in 30 to 90 minutes. The disadvantages of this? Well, if our drug is extensively metabolized in the liver, we will have really poor bioavailability going down this oral route, which may either make the drug non-viable or require some very high doses that could put a lot of stress on the liver. It'd be much easier for a generic manufacturer to copy. A simple tablet, the second the exclusivity is up, it's going to be copied. And you can have potentially poor medication adherence because patients may forget or refuse to take their medication, as discussed in the LAI part of this. Higher risk of relapse due to that aforementioned adherence issues, and many other similar AP drugs exist. We would need another way to differentiate our product from the slew of products already on the market. Now let's look at the last form we're going to discuss today, which is sublingual, and this is arguably the rarest form of administration for an antipsychotic. There's only one example I could find, which is asenapine. But sublingual antipsychotics are administered as a pill or tablet. It dissolves under the patient's tongue, and ideally this only happens in a few seconds, because any longer would be uncomfortable. And this can significantly increase bioavailability because it's going right through those membranes in the mouth into the blood. It avoids first pass through the GI tract and the liver. So this gives you the opportunity to have higher bioavailability without having to use intramuscular or IV. And for an example, sublingual administration of asenapine, which was not originally a sublingual drug, increased bioavailability from 2% to 35% because the oral only had 2% bioavailability. But the area of the solution in the mouth can affect how much drug gets into your blood, and if you eat or drink too close to that administration, especially after, you can influence how much of it gets absorbed, which can be inconvenient for patients because it presents a kind of logistical issue. And as you can see, there's a little figure here. It's showing the pharmacokinetics of sublingual asenapine compared to HP 3070, which is just a transdermal version of asenapine. And kind of like with the oral, this peak is very quick. Hard to tell in this chart, but it's very much present in the blood at probably 20 or 30 minutes. So very fast to come on. So what are the pros and cons here? Similar to oral, sublingual produces therapeutic levels very quickly for immediate symptom control. It's non-invasive, like oral, but it has some of the benefits of the higher bioavailability that you see with more invasive methods like IV and IM. It can be flavored to provide a pleasant and delicious patient experience. There are very few similar formulations in the market for schizophrenia, and it can be dosed several times a day, similar to oral. The disadvantages, it's not as hard to formulate as an LAI, but it is harder to formulate because you have to consider dissolution in the mouth, has to happen quickly. Pills need to be dissolved in a certain part of the mouth, as mentioned, and eating and drinking need to be avoided after administration. And for patients, especially those with some cognitive issues, this can be a little bit difficult to understand and do consistently, which may provide issues with adherence. And even if they're trying to adhere, they may not be getting the levels that they should be getting in their blood, which would be an accidental lack of adherence. And in general, the same issues oral has with adherence, this may have worse because it's a little bit more inconvenient than oral. So we can discuss pros and cons until we're blue in the face, but the most important thing is which of these methods is best for the drug we are making. And I've written down some factors here and whether or not each route of administration is ideal, not ideal, or bad. So as we discussed before, if the drug is very extensively metabolized during first pass that we're making, LAI is going to be best, sublingual is going to work reasonably well enough, and oral is going to be bad. If our patient population has severe symptoms and cognitive dysfunction, again, LAI is best, oral is not great, but may be acceptable depending on the circumstances, and sublingual is going to be confusing and probably bad. If we're prioritizing CMC simplification, if we want to have a very robust manufacturing process that's not prone to error and will be easiest from a development standpoint, oral is going to be the easiest, hands down. Sublingual is not too bad, and LAI is going to potentially cause us some big issues. If our drug has potentially severe adverse effects and we may need to rapidly take patients off of it if they show signs of it, we're going to want to stick to oral or sublingual. They both come on very quickly, leave fairly quickly, so if a patient is responding badly, they can be off the medication in a matter of hours or days. LAI is very bad for this. They'll be stuck on that ride for weeks or months, so definitely not LAI. If we want precise control over PK in the patient, oral is probably best. So I didn't put sublingual as best here because there's too many factors that can affect the absorption from the patient, from the patient's own administration. But sublingual is a close second there. And LAI is the worst, again, just because it takes a very long time for that to fully absorb, and it's hard to have precise control over something that takes months. Thank you very much for listening to my presentation. Here are the references I've used.